Hello all, I'm Andrew Malley. I'm the CEO of Dignity Health Global Education, and welcome to another DHG Talks. We have a fantastic event for everyone tonight with our partner, Duke Corporate Education, who are the premier global provider of leadership education, and together we have our new Healthcare Leadership Academy for both clinicians and non-clinicians alike. I'm really happy to hand over today's session to our friend, Michael Chavez, the CEO of Duke CE. Michael has decades of experience in advising and teaching the biggest companies in the world. He has a new book, Rehumanizing Leadership, which was published earlier this year, and it's fascinating. In fact, it's so fascinating, the topic of rehumanizing leadership is actually the basis of tonight's event. So, Michael, over to you, and look forward to hearing everyone.
Thank you so much. Let's see, for that introduction, Andrew, I'm just making sure that I am visible here. Thanks so much for that lovely introduction. I'm delighted to be having this conversation today and hosting it with some of the top three. We've got three very top health leaders today to help us explore this question of rehumanizing leadership and what that really means in terms of healthcare, and specifically what it means for staff and patients. First and foremost, let me introduce Marvin O'Quinn, who's the president and CEO of CommonSpirit Health, the nation's largest nonprofit health system, which includes 137 hospitals across 21 states. Joining us also is Dr. Geeta Nayyar, who is, you'll hear me referring to her as Dr. G. She's a nationally recognized doctor and leader in healthcare information technology. She recently joined as the executive medical director of Salesforce and maintains her own active practice in rheumatology. Finally joining us is Chris Lowney, who's the vice chair of the board of CommonSpirit Health. And he's also been the managing director of, you might have heard of the investment banking firm, JP Morgan, in some pretty impressive places around the world: Tokyo, Singapore, London, and New York. And he's the author of 6 books, including Heroic Leadership, which has been translated into 11 languages. So that's our panel for today. I want to kind of frame this conversation before we jump in by kind of talking a little bit about what do we really mean by rehumanizing leadership, and what does that because that's kind of an evocative statement, and I want to kind of just frame it a little bit. Our work at Duke CE around this topic of rehumanizing leadership came out of the work that we had been doing with clients around this issue of dramatic change and complexity and uncertainty that organizations are facing. And of course, when we think about humans, we're not very fast. We're not great climbers, and our camouflage is pretty bad. So our survival skills all come down to how we come together in groups and how we solve complex problems. And that has been dependent upon 2 vectors of evolution. On the one hand, the vector of empathy brings us together, helps us feel each other's sort of pain, helps us imagine what it would be like to be going through what people are going through. And that helps us come together and come together as groups and have a social kind of cohesion. The second vector of evolution, of course, is the one of what we call purpose. It's the idea of kind of being curious about why things are happening, and it enables us to think about the future, wonder about big complex problems, and think about possibilities. And our contention is that modern organizations have pretty much inherited a system that, to some extent, tamped those tendencies down, and all in the name of efficiency. Now, that's all been great. It's lifted billions of people out of poverty. It's made them healthier in general. But we're at a point in history where we think we need to have a revisit and look at how we build in more humanity into our organizations, so that, not just so that they can survive, but so that they can thrive. And so with that, I want to start off by turning our attention to Marvin O'Quinn. If you could just kind of think about, we want to kind of open up and talk about this issue of change, which is kind of what I opened up with, this idea of change and rapid change and uncertainty. As president and CEO of CommonSpirit, which is the largest not-for-profit health system in the US. And as someone who's experienced a range of sort of public hospital systems, what have you seen really changing, especially recently?
Well, the pandemic really brought about a lot of change to how we ran or run our operations. It really stresses the importance of visible leadership, the importance of teamwork and collaboration across many sections of our organizations, because we were faced with unknown, challenging questions in which we had to get answers to quickly and then get them implemented quickly. And so we had to change our structures in order to accommodate that and to do that in a very rapid fashion. And it really put an emphasis on communications across our system and across the various groups. And so we implemented new structures that we hadn't had before. And it was clear to me that we weren't actually talking enough to each other because we're large and we're spread out across the country. And so once we started talking, some groups every day and other groups 2 or 3 times a week, we were able to really take on big challenges quickly, find solutions, and then get them implemented. So a number of those communication structures that we put into place, I intend to carry on after the pandemic is over, because I think it makes us a more agile organization. It breeds teamwork and collaboration across many different sections of our operation, and also ties us all together. There are a number of things that didn't work so well. As healthcare entities, as you know, we've been pushed over the years to become more competitive entities, to be a part of, sort of capitalistic structure of competition drives down costs, drives up quality. It pushed us away from our public health roles that we played when I first entered the field. And the pandemic brought back that role. And so folks are now looking at us not just as healthcare providers in the traditional sense of I get sick, you come in, we take care of you, but in who's going to vaccinate me when the vaccinations are allocated? Who's going to test me? Who's going to take care of me or take care of my family when these circumstances occur? And people are now looking at hospitals to play that role in their communities. So a lot of the things we were doing before in order to be competitive, just-in-time inventories, buying a lot of our key products offshore, minimizing our staffing costs by using really strict staffing models. All those things drove down our costs, but they did not serve us well in the middle of a pandemic, and we've had to adjust to that. And we have. So some of this we're going to carry forward as after this is over, and see if we can run our organizations a little differently than we did before. And some of these things we won't. But the key for me is communications and really visible leadership. We've asked our hospital presidents that they are to be leaders internally and externally in their communities and in their hospitals. And they've lived up to that. And I think that has served us well as we moved through this and met this challenge.
I love that idea of kind of being in the community, because one of the concepts of rehumanizing leadership and of purposeful organizations is the idea not just of thinking about our economic logic, what allows us to survive, but our relationship with communities and people that allows us to thrive and flourish over time. So it's a great link to this idea of rehumanizing leadership. Dr. G, over to you. As an experienced medical doctor, and now the executive medical director of Salesforce, and working with quite a lot of health systems, how do you see technology changing the healthcare industry and importantly, the patient experience?
Sure. First of all, thanks so much for having me, Michael. Really appreciate the opportunity to be here with all these bright minds. The reality of what I think we've learned is that there are things that we need to automate, right? There are things that we need to really meet the patient where they're at. And then there are things that cannot be automated, right? Which is, I think, essentially the topic of this webinar today, right? Which is how do we keep the human factor front and center, particularly at such a historic time and a historic time in healthcare, but at the same time, connect the physician experience with the patient experience.
Yeah.
And realize that there is a role for digital technology to empower the human relationship, but it is all with an eye towards actually keeping the humanity in medicine. And I think that's really the conversation I've had with every health system today, which is physicians are burnt out, nurses are burnt out, and that affects patient care, right? So what tools does Salesforce offer? What tools generally in the industry are there that can help every system today make both their physicians happy as well as their patients happy?
You know, I love this idea of sort of rehumanizing technology, right? So technology in and of itself can be dehumanizing, but if applied properly with a real eye towards the patient experience, we can actually, and the physician and nurse experience, for example, we can actually elevate the humanity and make it easier.
You are spot on. And I'll give you a simple example, right? This dialogue right now, right, Michael, I'm able to look you in the eye.
Right.
There's no hiding from you, right? We've actually had patients at our clinic say that doc, everyone looks me in the eye right now. It just happens to be through a webcam.
Right.
But when we come into your clinic, when we come into the hospital, you're so busy on that computer and looking over there that you never actually talk to us. So the technology has, interestingly enough, because we've been forced into a virtual atmosphere, has actually forced eye contact, where technology prior forced us to lose eye contact.
Right.
It's a simple workflow issue, but it is an incredibly humanizing experience to look someone in the eye. And
I think it's fascinating. I think a lot of organizations have had this experience of a great leveling effect of, especially when we have distributed teams in sort of a headquarters, that everyone's kind of now on the same level. And it's kind of been interesting to see connections go up. That's actually a theme we're going to get into, this idea of connections and interaction. So thanks for that, Dr. G. It's fascinating stuff. Chris, from your perspective as vice chair of CommonSpirit Health, what do you see from that kind of angle as the primary challenges facing the industry?
Thanks, Michael, and thanks for the chance to be part of this discussion. It's going to be a wonderful interaction. So, look, I mean, dozens of books are written each year on the big challenges facing healthcare, and I'm not going in 2 minutes to try to summarize every challenge that healthcare faces. So maybe I'll just try to encapsulate one idea and the challenges, the complexity that I see that comes with it, and then maybe an implication or two for leaders. And you know, in a way, Marvin kind of presaged where I'm going. The challenge of kind of moving, evolving from an industry that is mostly known for treating people who are sick, really important, will stay important. But also adding a kind of a deep dimension of keeping individuals and communities healthy. So a kind of a fundamental evolution, and this is something that will long transcend pandemic, and that we were talking about well before pandemic. And you know, all of us in healthcare are familiar with some of the challenges, difficulties of pulling this off. For example, people talk about how do we re-aggregate the way payers and providers interact, and where the incentives are and how people are paid, and there's a whole pile of thorny problems there. But I might want to focus on a different set of complexities, namely that when you talk about an idea of keeping a community healthy, and you know, when we say health, I think most of us don't just think about our physical bodies, we also think about spirit, we also think about mental health. To pull that off requires a completely different set of skills and a different kind of ecosystem than what traditional healthcare providers have as their core skills and have as their core ecosystem. So when you think about it, we, as healthcare providers, we of course have to up our game, change the way we do outreach, change the kinds of interactions we have with individuals and communities. But we also have to pull together a new kind of ecosystem, you know, like community organizations and social service organizations are going to have a role to play here, church groups, potentially 12-step programs, those who are involved in housing, in food security, and so on. And sort of pulling all of that together is no easy task. And
Right.
just for 30 seconds, a leadership implication or two of all that. You know, for one thing, it's going to require people to be more pioneering. In other words, it's not like there's a playbook on this is how you build a good network for public health, community health. There was in a traditional sense, but in the sense we're now talking about it, some of it is going to require folks who are pioneering, willing to try more things, willing to try and fail, willing to reach out. And it's also requiring I would call a deep level of perseverance and commitment, because none of this is going to happen in a year. The fruit is not going to be abundantly apparent in 6 months. And so we need leaders who are willing to say, you know, look, this is the right thing to do. This is in line with what I should be doing. This is in line with mission. I'm going to hang in there, even when it's frustrating, make efforts, try to move us inch by inch in the direction we all want to go.
You know, it's fascinating, the complexity of what you're talking about. You're talking about really redesigning a system beyond our traditional concept of a system. You're talking about an ecosystem, right? And we don't have control over that whole ecosystem. So we've got to be in this intervention kind of mode where we're experimenting, trying things. And that's a very different way of operating than sort of the more kind of linear approach that we've taken in the past. So huge leadership implications, right? I mean, I think that's one of the things that we found in our work is that there's part of our business that's going to stay pretty, you know, linear, but there's a big chunk of it that isn't. And so we have to kind of change and shift our thinking and our behavior. So I want to take this conversation to sort of the COVID-19 health crisis, because, you know, we published this book about rehumanizing leadership in February of 2020. And so who knew that this was going to unfold? This discussion around dealing with complexity and coming up with purpose and meaning was going to have such profound implications. But it you know, Marvin, you talked about the healthcare system changing, you know, having to pick up sort of what's going to stick to what we want to keep, and let go of things that aren't really serving us anymore. Let me ask you, Dr. G, what's your kind of idea there? What do you think have we learned from this? What needs to stay? What have we learned needs to stay about our healthcare system? And what is this crisis showing we really need to let go of?
Sure. So I think the first thing that we've realized is how fragile all of this is, right? This has been humbling for every health system, every doctor, every patient, every mother on the planet, right? So I think we've realized how important it is to humanize healthcare and to set up the system for success. And all of us have a role in that, right? Everyone on this webinar, everyone watching, and all of us as individual citizens. So you can also have the best provider system, you can have the best doctor, but if you as the patient don't take some responsibility, right? If you don't wear a mask, there's not a whole lot we can do, right? You will not be set up for success when you walk through that emergency room door, no matter where you are, right? At the same time, anyone who walks in that door, we want to ensure that they have the best opportunity to see the best in class staff, the best in class facility, the best, you know, vent at this time. So I think we're just realizing that the system is fragile, and there is basic infrastructure that we need to put in place, right? Technology being one of the things we've realized has helped us the most through this pandemic. Again, just like this webinar, we as docs are seeing patients now in a way that we never have, and it's helped us scale. So I think it's keeping in mind the fragility, but also really bootstrapping it and understanding that by investing in certain infrastructures like the digital highway, that is what is going to get us from today to tomorrow, and also get us to a place where hopefully, you know, we don't see an attrition of doctors and nurses and folks that leave the field, because that I think is going to be the next wave of this pandemic. So we've got to set people up with the right tools, the right infrastructure, to then humanize the entire experience and lead to proper outcomes.
I love this idea of technology as a means to help build personal responsibility for one's health, right? This kind of, I guess you can help that with self-service tools, for example, right? Make it
you got it
for me to kind of manage my own health. Yeah.
You know, the basic questions that any patient has, Michael, I mean, we all go to the doctor for this, right? Because I have a question. I have this question about the flu shot, right? I have this
Right.
question about this vaccine that hasn't come out yet. So we go to answer questions. And if you think about basic education and health literacy, right? One of the things that I've realized in this pandemic is how much more time we need to spend counseling and how far that goes. Because if you actually spend the time with a patient and explain to them why they have to wear a mask and how a virus is spread, whether it's COVID-19, the flu, or any upper respiratory infection, they are more likely to be compliant. Right? When you just give a patient a prescription and they walk out of your office, if they don't understand why they have to take that medication, they're not going to take it. We're all
Right.
human, right? And likewise, I would say the same about myself. So the education and literacy and the opportunity for technology to teach and educate, I mean, this is right up your team's alley, right?
Right.
Is profound and impactful for a lifetime. So I think we have to think about that.
The use of technology to enable people to know why, right? This is one of the biggest motivators of human behavior. And that's kind of what our research was all about. So it's incredibly insightful and helpful. Marvin, you talked about the idea of the COVID-19 pandemic stressing the system and you talked about communication, but you also kind of hinted at this issue of the sort of model was based on sort of an capitalist efficiency model. How do you think you're going to move after this pandemic in thinking about that model? And what are you able to design into the system to take advantage of what you've learned? Oh, Marvin, I think you're on mute. Sorry.
I am hopeful that the public and the political powers will see the role that hospitals and healthcare systems have played as adjunct to the public health departments, and will want us to continue to play that role, or to some degree, as we go forward. Because a lot of what has happened to healthcare systems over the years has been in response to public policy.
Right.
So public policy was, we want you to become more competitive. Public policy was, we want you to operate in a way like any other industry operates, and we believe that's the best course of action, and that will keep the gross national product which hospitals occupy from going from 13% of GNP to 20%.
Right.
Well, of course, we are at 20%. It didn't work, and that's because healthcare is a unique industry. It really is a social service industry, because we're dealing with the health and lives of people, and each individual is so different in terms of the approach that you have to take with them, where they live, what their history is, what your genetics say. All of these dictate the treatments that we're going to provide for them. And yes, there are protocols that we can follow, but again, people are in fact unique. So what is happening now in terms of, well, I talked before about just-in-time inventory. Well, we're going to keep 90 days plus inventory on hand going forward and for the foreseeable future. That's a complete change.
The opposite of just-in-time, right?
That's the opposite of just-in-time. It's a complete change from where we were just 9 months ago. And in fact, in some states, in the state of California, the governor has signed legislation making that a legal requirement. So it's not just us acting on our own, it's the government seeing this is necessary for these types of circumstances. So we're gonna do that. We've invested ourselves in onshore organizations that produce PPE, so that we could have a guaranteed supply made here in the US to get into our institutions when we need them, so we wouldn't be scrambling again as we were back in March. We've been pretty flexible with our staffing models because we had to be, because staff were burning out and we needed to help the nurses in the ICUs to take care of those patients. And I'm hopeful that some of that work that we've done will also continue on as we go in the future. The other thing that we're going to do, because what COVID has done is it sped up trends that were already happening. So we know, and we've said for years, all these folks come into the emergency room, some of this care can be taken care of, it's better taken care of in an urgent care center, in a physician's office. Well, now they're getting it virtually. And our emergency room volume right now is 20% below where it was this time last year. And we don't expect that to come back, because we believe people have found another way of getting care for these minor issues that they didn't need to get in the emergency room. All the projections that we see show that there's a whole host of service lines that are depressed now, artificially by the pandemic, that are not going to come back soon as people find different ways of getting treatment or physicians change their treatment patterns. And so we'll have to adjust our acute care management structure to deal with that.
Yeah.
And so what we look at now is that the trend towards outpatient, the trend towards virtual care, the trend towards what we'd call risk-based population management structures has been accelerated by COVID. So as we come out of COVID, the number one question we're looking at is how do we invest our capital?
Right.
Because someone once said that if you want to know what someone's strategy is, look at how they invest their money.
Right.
And so we're starting to look at, we're probably invest 90% of our capital in our acute care structures. Hospitals have voracious appetites for capital. We're going to have to find a way going forward to shift that. Now, it's not going to go from 90% to 10%, but it might go from 90% to 70%, or maybe even 60% if we're lucky, as we build out the ambulatory portion of our operations and the post-acute care of our portions of our operations. And finally, I would say that we will also push towards value-based care, capitation, and other types of value-based products. The organizations under the pandemic that had more of that did better financially. Kaiser, Geisinger, or just to name a few, Intermountain, who had big insurance plans, they did much better financially under this than hospitals that didn't. As we look at our own operations, we have 30% of our volume, our revenues in value-based products. Those products performed better than our traditional fee-for-service products did for obvious reasons. So we're going to want to push that even farther as we go forward. But to be successful in that, you have to have the whole continuum of care under your management: outpatient, inpatient, and post-acute. And as Chris said earlier, most of our hospital leaders are not trained for that.
Right.
They're trained to run hospitals.
Right.
And so we have to have a broader perspective to manage the entire system. And so we have to develop those capabilities to do that.
Got it. So system and capability. And I guess I hear sort of an implication in that too, Marvin, that we're talking also, I'm curious about what's happened in terms of this effect of understanding these different points of delivery better and making it more fit for purpose for the occasion of healthcare treatment. Has this had a democratizing effect as well? Because I'm also thinking about the effect of the pandemic on marginalized communities.
Well, it will, and I'll just say, we are a mission-driven organization, and we have facilities and hospitals in really very poor communities, and we view ourselves as the voice of the voiceless. But we also recognize the shortcomings, and we haven't done as much as we could do. And so our board has incorporated in our goal structure a goal built around health disparities. And the technology that Dr. G talked about is going to enable us to do things we weren't able to do before in terms of getting into these communities. So we don't have to go and build clinics if we can get, because everyone's got a phone. They can get to us through their phones or through their computers. Right. They just have to know that we're there.
Right.
And through our connections in each of these communities, we're going to be able to do that. And one of the areas where, and we were talking about this earlier this morning, the vaccine distribution. How do we make sure that these disadvantaged communities that have been absolutely punished by this disease don't get left out or fall between the cracks when the vaccines are being distributed?
Right.
And we can do that. We're thinking about how we're going to be able to do that. And for the foreseeable future, I would say that that's going to be a key part of our sort of goal management structure, different projects that we're implementing around health disparities and access to care.
Terrific. Dr. G, this idea of moving from, kind of silo-based or a hospital-based view of the world to one that's much more systemic, much more community-based. What in your view, what in terms of the pandemic, especially what we've learned, what have we learned how technology can enable that?
Sure. So first of all, I completely agree with Marvin's points. I think he's completely spot on. And I think that's what we're learning again, is we have to meet people where they're at, right? And I also want to say that technology is not a silver bullet. There are certain technology barriers that are going to exist in certain communities and populations. I myself work at the University of Miami, in a very underserved part of the population here in South Florida. And I'll tell you, just anecdotally, I was with a medical student and we were doing virtual visits. This was the clinic day where we were doing virtual visits. And the medical student came in and said, "Doc, I can't get them, their video's not working. Their internet's not good enough. Their infrastructure, right? Their Wi-Fi, et cetera, wasn't working." And I said, "Well, you're talking to him, right? I just need to talk to him. It doesn't have to be a video chat." Right. And I said, "Let me show you how we do this," right? And we had a conversation about this gentleman's hypertension, why he wasn't taking his medication, what we needed to do to fix his diet. And it was a perfectly acceptable clinical visit. Right. So I think that when we think about equity in care, we have to be very mindful of the communities that we serve. We do, of course, have to practice, equitable healthcare, but that might look different in different populations because we need to adjust to their environment. But I think the point is we need to have the infrastructure that will allow us to pivot, right? So if we can do a video visit, that's ideal in this environment. In my world, I will say as a rheumatologist, I will prefer an in-office visit because there are certain complexities that we need to see on a physical exam. Babies still have to be caught by the doc, right? So technology is never going to replace many things, and that's okay. But we want it to be appropriate time, the right care at the appropriate time, in the appropriate place, and with the right cultural sensitivities and the right socioeconomic sensitivities.
And Chris, what's your thinking on this in terms of what we need to keep and let go of and through the learning of this pandemic from your perspective, from a governance perspective even?
I'll tell you something that I hope we keep, that to me is a hugely hopeful, promising sign amidst the terrible crisis we've all been living through. And that is the level of adaptability, creativity, resilience, willingness to change, innovation has been absolutely phenomenal over these months. And everybody knows that apart from the pandemic, this industry is in a transformational moment, and you need exactly those kinds of capacities in human beings. And what I've seen as a board member over these last months, pandemic hits, protocols and procedures need to change in very, very short time frames. Boom, no problem. A shift to virtual happens quite quickly, dramatically, as implications for people who work in technology, for caregivers, for those who are worried about security. Done. Within the world of CommonSpirit, we stood up new lab facilities, a surge hospital, folks who thought their job was X and who had done X for their career, all of a sudden had to do Y and kind of seamlessly did that. And those are exactly the kind of cultural qualities you need in any organization in the kind of world we're living in, certainly in healthcare, but across industries. And I think that the question to me that comes along with it would be this. To some extent, we had to adapt these months. I mean, there was no other choice. We had to adapt. And so the question is, when the world returns to something closer to a new normal, whatever that's going to look like, are we going to be able to hang on to that gene that has been so prominent these last months that we've discovered, namely our ability to transition, to do new things, to try new things, to innovate, and so on. Humans and organizations always say that change is good and they have a great change appetite. And in 3 industries, I've never seen that ever to be the case. So the challenge will be, will it be different this time? Can we hang on to that spirit of innovation that we've discovered in ourselves?
Well, let's hang on to that point, because what I'd like to do is transition just as our final kind of point of discovery is this idea of leadership. And to do that, I want to just share with everyone a bit of sort of our thinking on this topic and kind of get us thinking about leadership. Let's see. I don't seem to be able to see where I can share this, but let me just have us think a little bit about leadership. While I'm doing this, I think what would be helpful is for us to, let me see if I can just give this one more shot. Here we go. Got it. Okay. We have thought about change in a couple of different ways, and I want to just kind of build this slide quickly so that we can kind of understand it. If you thought about change and sort of the idea of we're managing work and we're managing kind of relations, right? That's the vertical axis and the horizontal axis. And then on the vertical axis, we're managing everything as leaders from strategy to operations. And on the relational side, we're managing collective organization change, but we're also managing people interactions on sort of more of a bilateral basis. And those have all gone through shifts, right? Our strategy shift has gone from planning and analysis to purpose, empathy, and meaning. Bigger guardrails, strategies change a lot more, so we have to rely on something more stable. Operations have gone from this efficiency model to one that's more about readiness, to Marvin's point, maybe even building in redundancy, not just efficiency. Organization change has gone from linear to exponential. So Chris, you just mentioned this high degree of change that we're having to kind of get used to. And people interactions, both inside and outside the system, in other words, patients, communities, and our staff we're going from sort of a more transactional approach to people to one that's much more whole person based. And this has huge impacts on kind of our levers, which we think are these. You know, we are, as leaders, we have to do more shaping of culture. We have to enhance collaboration. We have to build narratives and meaning for people to align them. And we have to create at the sort of team level and the operations level, more openness and trust if we're going to solve big problems together, just like Chris has talked about. So I'm going to just pause that. And I'm going to ask us to kind of come back to this question. And I'd like, Chris, maybe you could kind of continue the thought. What's the leadership? How do you see rehumanizing leadership from your perspective?
To come at that, Michael, I think I'm going to start with the title that we use for our whole session, Rehumanizing Leadership. And, if people misunderstand that, they assume, oh, there's something wrong with the leaders in healthcare organizations and we have to make them more human. And, I have absolutely never found that to be the case, quite the opposite. To me, and especially during the pandemic, we've seen these deep human mission-driven qualities come out from the top to the bottom of our organization. And to me, and I think there's the point you're getting at, we force human beings to work within a healthcare system that's incredibly complex, that has so many moving parts, that puts so many different financial, regulatory, and other kinds of pressures on them, that it can be difficult for them. They have to be a bit heroic, I would say, to hang on to this deep sense of mission with the other pressures that come their way. And so maybe I'd in a minute, just give one quick leadership implication from a governance boards and maybe another for leaders more generally. For boards, to me, the humanizing or rehumanizing question might be, okay, look, I know in every board meeting of every organization, every industry on earth, we're going to talk about finances. That's always going to be in the agenda. But are we taking enough care of the underserved? Is patient satisfaction good? Is the quality of our care good? The people who work in the place happy? Those kinds of things will only come onto the agenda if people in governance say, no, we have to talk about this. Of course, we have to talk about financials, but we absolutely have to prioritize this as well. And Marvin mentioned that we've established as one of our measures things that go in this direction. So to me, an implication for boards, for governance, do you hang out there as one of your core priorities, metrics, and so on, the things that might fall under the umbrella of a human healthcare environment for patients and so on. And a quick implication for leaders in the area themselves. I have enormous empathy for leaders who, we force to juggle so many intense priorities. whether it's multiple regulatory regimes and what that puts on you, compliance, financial constraints, and so on and so on and so on and so on. And to kind of keep paramount on that list the importance of how we treat our people and how we treat our clients and patients, that to me requires a sort of an act of will that's a little bit heroic, a kind of a dedication to mission that sort of stays there day by day. So to me, that having that kind of heroic will is an implication for leaders in the field.
The antidote to this complexity and uncertainty is clarity around the why, like why we're here, right? And we're running out of time, but I want to try to. We got a question that I think is an important one, and I want to ask Marvin and Geeta to chime in on this one. And I think maybe we could filter in some leadership implications into this question. But the question is really, how can we, in our medical systems, balance being reactive with stability and with innovation? So we've got that. This is a question that came in over the next 3 to 5 years. We've got to be reactive and we got to change, but we also have to be stable. And so I want to see if you could maybe frame that in terms of leadership for us. It's a great question. Marvin?
Well, I view good, solid leadership from a strategy perspective as this term balance. So you have on the one hand what we might call a structured planning process. Every year we look at the numbers, we look at the future, and we lay out the goals where we're going to go. And these used to be 5-year plans. At some point they were 10-year plans, and then people realized we don't really know what's going to happen after 3 years. So let's get rid of all this other stuff. So, but you have to do that because you have to think through where you want to go.
Right.
Now, I often use the quote from Alice in Wonderland: if you don't know where you're going, then any road's going to get you there. But you have to balance that with being opportunistic.
Yes.
And that means allowing the folks who are coming up with ideas or pushing through new business plans, giving them a voice and investing in some of those plans, investing in some of those programs. Sometimes you have to go outside the cycle. And so my viewpoint has always been, if a good plan is put in front of me that wasn't in the original budget document, I don't really care. I'll find the money to fund it because it makes sense and it's going to help my organization. And more importantly, it's going to send a message to everybody else that, hey, we're flexible.
We're flexible, yeah.
And this organization is not just interested in what it said it was going to do and sticking to that, but it's also willing to take risks and to invest in its people. And so for me, I say, look, if you got an idea, we're going to take a look at it. I don't care if it's off cycle or not, and we'll fit it in somehow if it makes sense, so you don't miss opportunities.
Terrific. It's that move from handcuffs to guardrails, or a strategy is a strong idea, but loosely held. Geeta, we got 1 minute. I'd love to get your thought on this one.
Sure. So again, Marvin and I are cut from the same cloth. I love that answer, Marvin. In short, it's about the leadership, and leadership must reflect its constituents. And I will tell you that every doctor in every household right now is the mother of the household. It is the woman of the household. Dad might be bringing home the health insurance, but mom is hiring the doctor, firing the hospital, talking to the nursing home. So make sure your leadership looks like the healthcare population that you are serving. Brown, purple, male, female, it is critical. It is the only way you know if you're being reactive or innovative. Your leadership will inform your strategy, and your leadership must reflect the population and the constituency that you are serving, period.
Terrific. Mission driven, but also, flexible, but also reflect your communities, build diversity and inclusion and belonging into your organization so that you reflect the communities you're serving. It's a brilliant way to end this conversation. And I want to first thank Chris, Marvin, Dr. G. I really love this conversation. I wish we could go longer and do double clicks on all of these, but I certainly learned a bunch, and I hope folks joining today did as well. I'm going to hand it over to Andrew.
You've caught me by surprise. I was quite absorbed by what I was hearing there. So thanks very much for that. Thank you everyone here. And thank you to Jukesy for hosting this event. You can get more information about our work together with Jukesy at dhg.org. where we have our Healthcare Leadership Academy, which is just a fantastic platform for learning and engaging. And at this time where learning is so important, we encourage everyone to inspire their friends and colleagues. And to do that, we're offering a study buddy scholarship at the moment where people can bring their friends along for free to study with them in order that we can all improve and get better and learn about some of the themes that have been discussed tonight as well. So with that, thank you everyone for participating, and thank you to all those who were watching.
Thanks a bunch.
Thank you. Stay well, everybody.
Thank you.
Thank you, guys. Nice to see you.
Thanks again, Marvin. And thanks everyone for your great human responses. I loved it. Take care.
Michael, you did great.
Take care.
You're a great
Thank you.
moderator.
Thanks,
Thank
Dr.
you.
G. Appreciate it.
Bye,
Hope
guys.
to
Bye.
see you all soon.
All right.
Take care.